Page number 337 onwards, moderate and severe acute malnutrition. So moderate acute malnutrition, there is the presence of malnutrition, but it's moderate, it's not that severe. Okay, so the scores, the anthropometric measurements that you do and the scores that we check, okay, the standard deviations that are less severe as compared to severe acute malnutrition. Okay. So in children who are aged between 6 months to 59 months, okay, the moderate acute malnutrition is defined as there is moderate amount of wasting, not complete wasting. Weight for height is between 3 and 2 standard deviations. There is a mean average height and weight for a healthy child, okay. There is a range of average weight for height for a healthy growth and development. If the child's average if the child's weight for height is 2 to 3 scores less than the average weight, okay, given by the World Health Organization, it means the child is suffering from moderate acute malnutrition. Or the mid upper arm circumference, which is very common. Okay, mid upper arm circumference. It is if it is equal to 11.5 centimeter and less than 12.5 centimeter. Okay, but not less than 11.5 centimeter. If it is less than 11.5 centimeter, it's severe acute malnutrition. Okay, but if it is between 11.5 to 12.55 centimeter, it means the child is suffering from moderate acute malnutrition. Coming to the contributing factors, lack of nutritional advice, okay, anticipatory counseling, poor healthcare access, contaminated environments, poverty, okay. People who are living in areas which already have people who are already living in areas with high prevalence of diarrhea, pneumonia, malaria, or any communicable diseases, okay. Any place where there is a high prevalence of these communicable diseases, in those areas also moderate acute malnutrition among kids is very common. Then parents not having a good education is also contributing factors, not fulfilling the immunization, okay, not following the universal immunization schedule. Okay, that is also another contributing factor. Coming to the complications of moderate acute malnutrition, there is nutritional stunting. Okay, the child will not have an average height for its age. That is new, and just because of improper nutrition, not able to, when the nutritional requirements are not fulfilled, the child is not able to reach up to its milestone height. That is nutritional stunting. Then infections, okay. Malnourished children are prone to infections. We know about the vicious cycle of infection and malnutrition. So that happens here as well. Delayed development in children, okay, any type of development, cognitive development, mental development, physical development, okay, all these developments are delayed. Non-communicable diseases are also common in later stage of life, okay. A child who was malnourished during their young age, in later stages of life, there are high chances that they may suffer from lifestyle-based diseases, non-communicable diseases. High morbidity and mortality rate. So since the infection rate increases in a malnourished child, that automatically increases the morbidity and mortality rate. Coming to the management of moderate acute malnutrition, community-based and home care-based management is done here. It has certain principles. Quality and quantity of nutrients matter here. Okay, even if it is a community-based, like from community healthcare centers or primary healthcare centers, you get nutritional supplements. Okay, it is of good quality, and the amount of nutritional supplements that is given to the child, amount of food that is given to the child matters to correct malnutrition. Breastfeeding, if the child is less than 3 years of age, breastfeeding should be continued. Promote breastfeeding among young mothers as well. Educate them about the importance of breastfeeding. Counsel the family members as well. Weaning diet, education and counseling based on weaning diet is given. Nutrient-dense food like ready-to-use supplementary food, ready-to-use therapeutic food. Okay, these are the different types of supplementary food provided free of cost to a malnourished child. Animal source of food items, eggs and milk, especially eggs and milk. Plant sourced for food items, malt. Okay, malt is the best way to improve the nutritional status of a child. Malting of cereals, legumes. Okay, malting means you have to make sure first the legumes or the pulses and or the cereals. Okay, they have to undergo germination, sprouting, and the sprouted pulses, cereals or legumes, you will sun dry it for a day. Okay, then you uh, grind it properly and then you mix it with milk or hot water and give it as a podridge, that is malt. That is the process of malting. Then amylase rich food is provided, that is anything that is germinated. Okay, sprouts. Nutritional supplements like mineral supplements, vitamin supplements, iron, zinc, iodine, potassium, magnesium, selenium, calcium supplements, vitamin fortified foods, vitamin A, D, E, K, vitamin B complexes, vitamin C. Prepare the meal in a hygienic environment. Nutritional counseling for the caregivers and parents. Okay, these all come under the management of moderate acute malnutrition. Ready-to-use supplementary food, that is the RUSP diet. Ready-to-use the full form is ready-to-use supplementary food. So to treat moderate acute malnutrition, RUSP is used. For treating severe acute malnutrition, RUFT is used. Okay, for children who are 6 months or older, RUSP can be given to them. You just have to knead it in package itself, properly knead it, then tear the package open. The child can have it as it is. Okay, 1 sachet per day, and 1 sachet can give 530 kilocalories for the child. Okay, so you don't have to refrigerate it, you don't have to cook it. Okay, you can conveniently store it, very easy to use. Okay, so that is the benefits of using RUFT. So what does RUFT has? It has it's a lipid rich homogenized mixture. It is water soluble food. Okay, it is also used in severe acute malnutrition as well. If uh, ready to use therapeutic food is not available, this can be used. And it contains the same nutritional content like the F100 therapeutic milk. Okay, like in hospital-based management of malnourishment, formula 75 and formula 100 is used. Okay, so the constituent of RUSF is very similar, or it is as same as the formula 100. Okay, if you have the nutrition science textbook, you can check it. What is the content of formula 100? Formula 100 means it gives 100 kilocalories. Okay. But formula 100 is in but this is in a dehydrated form. And can be formula 100, you have to mix it with milk, you have to mix it with water and give. This you don't need any mixing. Just open the packet and give it to the child. And there is no risk of contamination. And the blend used here is peanut paste, milk powder, sugar, oil, and it is fortified with multiple micronutrients. Skimmed milk powder is also used here, 24%. Vegetable oil, especially coconut oil, is used 21%. Peanut butter, 25%. Sugar is just 28%. It is sweet in taste. Then coming to severe acute malnutrition. This is the triple burden of malnutrition section. Chapter is moderate and severe acute malnutrition. Coming to severe acute malnutrition. So here, When the weight of the child is less than 3 standard deviation, okay, there is an average weight for height for every healthy children. But you call a child who, you will tell a child is severely malnourished when their weight for height is less than 3 standard deviation. Okay, it is less than 3 points than the average. Okay, based on the WHO growth standards. Then we say the child is suffering from severe acute malnutrition. And there is a visible sign of muscle wasting here. In moderate, it was not severe wasting, but here there is severe wasting. You will see that you can see the bony prominences of the body, child's body, skeletal system is visible. Okay. And bipedal edema. Bipedal edema means on both the feet, the child will have what to say, swelling. Okay, that is bipedal edema. Mid upper arm circumference, when you take the upper arm circumference, mid upper arm circumference, it is less than 11.5 centimeter. Okay, in moderate acute malnutrition, you must know the upper arm circumference is between, yeah, in here they have not mentioned the here F100 solution, they have not mentioned in this textbook, I guess. But if just check the severe acute malnutrition chapter from nutrition science textbook, same chapter, severe acute malnutrition from nutrition science textbook, go to the management or treatment section. Okay, there you will find in detail about F75 as well as F100. Okay. So mid upper arm circumference here in severe acute malnutrition is less than 11.5 centimeter, but in moderate it was, but in moderate it was between 11.5 to 12.5 centimeter. So this is the steps, okay. In severe acute malnutrition, we have discussed about the steps in detail. So step 1, when a child is admitted, okay, when a severely malnourished child, okay, protein energy malnutrition, kwashiorkor, marasmus, okay, severe acute malnutrition child is admitted in the hospital. Usually they have hypoglycemia, hypothermia, dehydration. Okay, these are life-threatening conditions. Okay, so day 1 and day 2, the child will be in ICU. Okay, some infections will also be there. So the first thing is you have to treat hypoglycemia. Okay, if the blood sugar level of the child is less than 54 mg per deciliter, immediately start the treatment for hypoglycemia. The child will be put on IV fluids and all. Okay. And then the second step is treating hypothermia. If the axillary temperature, that is the underarm temperature, is less than 35 degrees Celsius, okay, and you have to take a rectal temperature also, and if the rectal temperature is also less than 35 degrees Celsius, you have to rewarm the child, put a blanket over the child, cover the child in warm blanket, okay, place a heater or lamp nearby the child, or if the child is too small, less than 1 year of age and all, put the child on mother's bare breast, skin to skin touch. Okay, that's how you can give kangaroo mother care and feed the child straight away. The third step is to treat dehydration. Put the child on IV. Okay, assume that all the children with watery diarrhea have dehydration, and in some cases you should not use IV route for rehydration except in cases of shock. ORS can be given here. And correcting the electrolyte balance, NS solution can be given, ORS can be given. And correcting the infection, antibiotic prophylaxis will be begun. Broad spectrum antibiotics is given to all children. Amoxicillin, okay, that is the preferred one. If the child is severely ill, ampicillin and cefotaxime is given. And correcting the micronutrients. Sometimes the child will have sepsis also, so understand which all bacteria is infecting the child and accordingly to the antibiotic therapy. Micronutrient deficiencies, you will start giving supplements. Okay, vitamin A is given on day 1. Okay, even if there is edema or not, the edema, vitamin A prophylaxis is given based on the nutritional program. Folic acid is also given, zinc, iron. Okay, deworming is also done after the child has stabilized. Continuous feeding has to be started. The same F75 and F100 is given. F7, you start with F75 and slowly transition will start, and then you can give F100. Small and frequent feed is given. Every 2 hours feed is given. Even if the child is sleeping, wake the child up, give the child feed, and after let the child rest for 2 hours. Okay. Milk-based formula is started with F75. And when the child is responding to F75 properly, along with breastfeeding, gradually you will transition the child to F100. Then in step 8, catch-up of growth. Okay, this is the rehabilitation phase, the catch-up of growth phase. It can be done as an outpatient treatment as well. Again, here milk-based formulas, rough diet is continued. F100 is continued in rehabilitation phase as well. Vigorous approach of feeding is done here. Like you have to dose the child with food, okay, because the child has to catch up in growth. Then we have sensory stimulation and emotional support. The child has to be given tender love by parents. Okay, put the child in a very cheerful environment, lots of toys, young children to play along with. Play therapy is given at least half an hour on a daily basis. Physical activity is included as soon as possible. The mother has to be involved for comforting, feeding, bathing, play. For every activity, mother has to be involved. So that helps in sensory stimulation. Then finally, you prepare for follow-up, discharge the child, but still the child and the parent should follow up. Teach the parents about energy dense food, nutrition dense food. Okay, give structured play therapy. Ensure that and advise the parent or caregiver to bring the child for follow-up on a regular basis. Immunization is given. Vitamin A is given every 6 months. So these are the principles of treatment. Emergency treatment of shock and severe anemia. Fluid therapy is given in shock, okay, in severe dehydration. Ringer's lactate with 5% dextrose solution is given along with normal saline. Do not use 5% dextrose solution alone. Monitor the child for every 5 to 10 minutes. Okay. If there is an improvement, remove the IV and you can start ORS. And in case of severe anemia, blood transfusion is required if the hemoglobin levels are less than 4 gram per deciliter. Whole blood you can give, or fusamide can also be given. Packed cells transfusion can also be done if there is a cardiac failure. Then you can slowly start to give the child iron supplements for 2 months to replenish the iron stores. And even if the iron stores are replenished, still continue the supplementation. Don't abruptly stop the iron supplementation. Treatment of associated conditions along with malnourishment, there are other deficiencies or infections. So first is vitamin A deficiency. If the child is more than 1 year of age, 2 lakh international unit of vitamin A can be given on day 1, day 2, and after 14 days. Okay. If the child is between 6 to 12 months of age, 1 lakh international units of vitamin A is given. That is 1 whole teaspoon. Okay. A special spoon comes with the vitamin A syrup. Okay. So if you take half a teaspoon, that is 1 lakh. If you take complete 1 teaspoon, it is 2 lakhs. So the nurses, they know that, okay, how much dosage has to be given based on age. If the child is just between 2 to 5 months of age, very small child, okay, less than 6 months of age, just 50,000 international units is required. Day 1, day 2, and on 14th day, this vitamin deficiency prophylaxis has to be given. Dermatosis, it is because of zinc deficiency. Start giving zinc supplementation. The skin will quickly improve. You can put a barrier cream also, which has zinc, castor oil, petroleum jelly. Okay. Try not to put the child on nappies or diaper because that creates diarrhea rashes. If diarrhea continues, check, do stool microscopy, understand what is the causative agent for this diarrhea. Is there any worm infestation? Or if the child is lactose intolerant, check that as well. F75 has low lactose as compared to F100. Substitute the milk feeds with lactose-free feeds if the child is having lactose intolerant. You can give yogurt instead of milk. In rehabilitation phase, you can introduce milk once the child has stabilized. Osmotic diarrhea, when the sugar content in the food is reduced, it usually stops. So reduce the amount of sugar content. Use isotonic F75 solution for this treatment. And after a long time, you can introduce F100. If any parasitic infestation is there, mebendazole, albendazole, mebendazole, okay, these are anti-helminthics. This can be given. Then you have tuberculosis. If the child has tuberculosis, chest X-ray has to be done. Mantox test can be done. Acid-fast bacillus test can be done. If the child is positive for tuberculosis, a DOTS therapy will be begun according to National TB Elimination Program. Then we have an appetite test, okay, just to check the child's appetite, okay. Sugar water solution is given to the child. ORS is also given to the child if there is a dehydration. So when you do the appetite test, you have to use a very quiet corner, okay. Caregiver should be present for the appetite test, okay. Make sure that the caregiver is also washing their hands before they feed something to the child. Encourage the caregiver to be comfortable and in a very sweet tone, low tone, encourage the child to eat the rough diet that is ready to use therapeutic diet. Even if the child refuses, quietly encourage the child to eat the food. Don't force the child to have rough. And when the child is eating the rough diet, okay, a lot of water has to be given. Plenty of water should be there when the child is taking the rough diet. There are different phases to appetite test. In the phase 1, if the appetite is failed, if you see the appetite test is failing, the child is refusing the food, 130 ml per kg of food of F75 is given. Mix F75 powder with milk, and for every kg of the child, 130 ml is given. And if the child has edema, little bit less quantity of F75 should be given. 100 ml is fine. Sometimes the appetite may fail if the child has other complications like hypothermia, hypoglycemia, convulsions. In transition phase, again introduce the patient to the rough diet. Okay, edema, you will see a decrease in edema here. So you can give F100 here. You can switch F75 with F100 because it has more calories. And in the same ml, the quantity, the amount should be the same. The quantity should be same, 130, but you are switching F75 with F100. That's it. In phase 2, the child has a good appetite, okay, and there is a steady reduction in the edema. And you can give extra feed here, 10 ml of extra feed. and you can start the raft if the appetite test is passed. If the child has felt motivated to take the raft diet, okay, you can start the raft, because raft has around 530 calories, and per kg the child can now take 200 kilocalories and 6 grams of protein on a daily basis, per kg protein on a daily basis. That is a high protein diet has to be given. So this is the raft, okay? You again have to just knead the sachet properly, tear it, and then let the child squeeze and eat it, okay? Again, no refrigeration, no cooking, no preparation is required. Just knead the sachet, tear it, and give the child, okay? This has 500, one sachet has 500 kilocalories. And this is used for severe acute malnutrition, not moderate. So we'll stop the session here.